So Hollie, please take the podium. Hollie is a final year medical student at the University of Melbourne, and Hollie's going to talk to us about the incidence, predictors and outcomes of QTc prolongation in critically ill patients.
Okay, so hi everyone, thanks for being here today. So as we said, my name's Hollie. I'm a final year medical student at Melbourne Uni, and for the first 6 months of this year I was able to perform a research project with Ronaldo Bellomo, and we studied the incidence, predictors and outcomes of QTc prolongation in critically ill patients. So just to recap, the ECG is a trace of the heart's electrical activity. The QT interval is an area on the ECG which corresponds to the duration from the beginning of ventricular depolarisation to the end of ventricular repolarisation. This is reported as a value corrected for heart rate, which is known as the QTc, and a normal QTc duration is 430 to 450 milliseconds. So what's QTc prolongation and why is it important? So a prolonged QTc indicates that there's been a delay in the ventricular repolarisation period. This can predispose to development of premature ventricular complexes, and if this is recurrent, it can precipitate ventricular tachycardia. In particular, QTc prolongation has been associated with torsade de pointe, a form of polymorphic ventricular tachycardia. And any QTc which is more than 500 milliseconds is considered to be dangerously prolonged or at higher risk of potentiating ventricular arrhythmia. So why is this relevant to critically ill patients? So these patients are exposed to numerous risk factors for QTc prolongation. These include electrolyte disturbances such as hypomagnesemia, hypocalcemia and hypokalemia, advanced age, increased illness severity, as well as many medications including antimicrobials, so macrolides, fluoroquinolones, azole antifungals, antiemetics, antiarrhythmics, specifically amiodarone, and antipsychotic medications. These patients are also at increased risk of arrhythmia generally, and they're at increased risk of poorer outcomes from arrhythmias due to their lack of physiological reserve. So while most risk factors can be mitigated, QT prolonging medications are often an essential part of management in the intensive care setting, and so clinicians are required to weigh the risk of therapeutic disadvantage if the medications are ceased versus the risk of QTc prolongation and potential arrhythmia if the medications are continued. So our aim was to study the clinical impact of QTc prolongation in the intensive care setting with the objectives of comparing patients who developed a prolonged QTc more than 500 milliseconds at any time during their admission with patients who maintained a normal QTc less than 500 milliseconds with regards to their risk factor exposure, the incidence of ventricular arrhythmias, and the requirement for intervention for such arrhythmias. So we performed a prospective observational study of patients admitted to our intensive care unit at the Austin Hospital in Melbourne during a 2-month period. Exclusion criteria were anyone with a permanent pacemaker or AICD, and any readmission episodes were excluded from the study. In order to calculate the QTc, a 12-lead capture ECG was performed daily on all patients between 3 and 8 a.m. as part of standard nursing practice. And to detect arrhythmic events, routine continuous 5-lead ECG monitoring was performed on all patients throughout the study period. And in terms of analysis, univariate analyses were performed. So our study included 257 patients comprising almost 1,200 patient days. The median age was 62 years, 58% of patients were male, and 56% of patients were surgical admissions, with the majority of these being cardiac surgery. So 93 patients, which was 36%, developed a prolonged QTc during their intensive care admission. These patients were more likely to have been aged over 80 years. They were more likely to have increased illness severity, as indicated by a higher Apache 2 score and increased vasopressor requirements. They had lower serum ionised calcium levels and higher serum magnesium levels. and they were more likely to have received more than one dose of QTc prolonging medication. These patients were also more likely to have an increased incidence of any ventricular tachyarrhythmia, specifically non-sustained VT, defined as less than 8 consecutive beats, and sustained VT, defined as more than 8 consecutive beats. But they did not show an increased incidence of torsade de pointe or ventricular fibrillation. They were also more likely to require any intervention for arrhythmias, including minor interventions such as supplementation, normalisation of potassium and magnesium levels, as well as more significant interventions, including requirement for amiodarone boluses or temporary pacing. They also experienced a longer ICU and hospital length of stay and greater mortality. So I'd just like to draw your attention to this finding. So regardless of QTc duration, in our patient population, 98% of ventricular tachyarrhythmias were resolved with just minimal intervention, so that was electrolyte normalisation or expectant management. Whereas, also I'd like you to note that no patients died during the study period directly due to an arrhythmia, and only one patient required an amiodarone bolus and one patient required temporary external ventricular pacing. So what does this all mean? So patients in the prolonged QTc group had higher serum magnesium levels. This was likely confounded due to the fact that we administer magnesium sulfate routinely in any patients who are experiencing ventricular ectopy in the unit. Patients in the prolonged QTc group were more likely to have non-sustained and sustained VT, but not torsades or ventricular fibrillation. And this contradicts the current literature, which suggests that torsades is common and is commonly life-threatening in patients with prolonged QTc, so this was an interesting finding. The majority of arrhythmias in both groups resolved with either expected management, electrolyte supplementation, and no patients died as a direct result of arrhythmia. So it is possible that because of the continuous monitoring, we were able to detect more arrhythmic events which were minor and would otherwise have been self-resolving, and so potentially our measure of success in managing arrhythmias was a bit slightly inflated. However, this finding suggests that we're very good at managing arrhythmia in ICU, and that perhaps concerns about arrhythmia in patients with prolonged QTc aren't so important. Patients with prolonged QTc experience greater length of stay and mortality, and this is consistent with recent research which has suggested that a prolonged QTc in itself is an independent marker of illness severity. So some strengths of our study was that we had quite a large sample size and a few exclusion criteria with the aim of creating very generalisable results to the entire ICU population. However, it was a single centre, 6-month study. Quite a lot of our patients were cardiac surgical, and so that potentially reduces generalisability. We were also unable to determine whether specific patients had the congenital long QT syndrome as pre-existing, which may have been quite a significant barrier or not a barrier at all, depending on what their status was. So where to from here? This was quite a basic preliminary study. We're hoping to expand the study from on the patient level to studying the specific day-to-day relationship between the risk factor exposure, the QTc duration, and then the incidence of arrhythmias to try and determine more of a cause and effect model. And our longer-term goal is to determine whether the suggested 500 millisecond cutoff as being high risk is appropriate in the intensive care setting, or whether this should be revised to be more relevant to our patients. So these are my references, and I'd just like to acknowledge everyone who helped out with the project. Thanks very much for listening.
Thanks, Hollie. Questions from the audience? Jeremy.
Yeah, thanks. That was a great presentation, impressive project. I was just sort of wondering about how it all worked. You obviously collected a lot of data, and how did you get all that data? Was that from chart review, or was there another method where the patients consented? How did it all work?
Yes, so following discussion with Professor Palermo, we decided that, and with the ethics department, we decided that was not required as we were only obtaining data from routine daily measurements. So I collected the data. It was collected from the kind of current admission records. So every day I would review the ECGs and the 24 hours of prior cardiac monitoring, as well as looking at the first morning arterial blood casts and UECs, as well as the previous 24 hours of daily medications, to collect all the risk factor information.
Okay, so you reviewed all the charts yourself to get all the data?
Yeah.
It's pretty fun. Thanks.
Any other questions? I'll come back this way in a second. Lucy.
Hi Hollie, thanks for your presentation. I have a quick one, and I apologise if I missed this, but I'm curious what the mean QTc in the longer QTc group was, because I think that relates to your question as to have we just got the cut-off wrong?
Oh, I'll have to have a quick look back at the slide. Oh, we're able to go back. I'd have to double check the exact figures with you. I'm sorry. Yeah.
Andrew.
My question would be, what was the overall prevalence of malignant arrhythmias in your group? Because I think the incident rate is going to be critical before you make any judgment about things. You need to have enough events of interest. So you need to recruit a high enough risk population before you can start saying, well, actually this doesn't associate, because malignant arrhythmia, whilst rare, is a very nasty complication. So.
Yeah, so we were somewhat constrained by the duration of the study period and the number of patients who came through. However, we had only around 4 patients who experienced any kind of malignant arrhythmia during the study period. So it did seem very low.
You're going to need a lot of medical students to look at a lot of ECGs to get enough numbers.
Jeff?
Yeah, that was a lot of work. Well done. I'm wondering if an alternative conclusion is that magnesium doesn't work for ventricular ectopy. Certainly it's not my practice. And so would you conclude that is true?
Well, I would, but I would also conclude that definitely wasn't a risk factor that was at play in our patient population. So it's definitely more likely due to other factors. But yeah.
And just a comment, if you're looking for a cut-off, the Bizet formula, which came around about 1920, does not accurately correct for your QT. You probably know that, and it's a linear problem, not a inverse square thing. So it might be useful to consider other ways of adjusting QTc if you really want to get a good accurate cut-off. Yeah. No, I completely agree with that. For this study, we just chose to use the Bizet formula because it would make our results more comparable to other studies which have also used that formula, as well as that it was kind of standard practice. But yeah, I think that would be very important.
Yeah, and just following on from that, in the toxicology literature, there's been the development of nomograms so that the cutoff is different at different heart rates, so it probably gets quite complex. Thank you, Hollie.
Thanks very much.